Good morning, everyone, and welcome. Welcome to our first CE presentation of the day with Alicia Wilkins and Dr. Ronnie Lee. Again, my name is Jamie Singletary, and I am happy to be here with you on the final day of our 2025 Within Summit. Just again, want to remind everyone that I will have contact information in the chat. The presenters also love your feedback and comment in the chat, so please utilize the chat for any questions that you may have, and we will do our best to allocate some time once we get through the content of the presentation to answer your questions. Again, these sessions are being recorded, so you will have the ability to go back and rewatch the presentations that we've had. We do not supply the slides to the talks. I've gotten a lot of questions about that, but we do have the videos there for you to look them over. So without further ado, I will go ahead and introduce my friends and colleagues. Dr. Ronnie Lee is a licensed psychologist in the state of Texas, Pennsylvania, and Florida, who completed his postdoctoral fellowship at Baylor College of Medicine, Ben Taub General Hospital in Houston, Texas, in 2023, and received a doctoral degree in clinical psychology from Alabazoo University in 2022. His prior clinical experiences have consisted of Jackson Memorial University of Miami Hospital, Regional Memorial Neuroscience Institute, and Clementine, Miami. Ronnie is currently a senior therapist at Within Health. And Alicia Wilkins is a licensed marriage and family therapist, certified eating disorder specialist and consultant, and certified mindfulness instructor. Alicia has 25 years of experience in behavioral health, working with children, adolescents, adults, and families. She has focused most of her career on working exclusively with eating disorders and has held various clinical and leadership positions at all levels of care. She has been instrumental in launching cognitive behavioral eating disorder programs in Florida and Virginia. She has specialized training in cognitive behavioral therapy, DBT, family-based therapy, and mindfulness. She has provided supervision and training for those pursuing state licensure, in addition to IADEP certification. She is the past president of the Richmond IADEP chapter, served on the IADEP National Board as chapter representative in 2021, and volunteers with the Eating Disorder Coalition to support advocacy efforts. Additionally, she has presented at local and national conferences. Alicia is passionate about ensuring that clients have access to care and believes that full recovery is possible. She also enjoys educating and coaching family members and loved ones, as well as supervising and mentoring the next generation of eating disorder professionals. And I'll turn it over to Alicia and Dr. Ronnie Lee.
Good morning, Jamie and everyone. Welcome, as Ronnie and I both have the opportunity to round out our last day of presentations. And as I usually do on the last day, I'm reflecting on all the presentations that we've had over the last couple days, and I'm just astounded by the quality of the presentations we've had. It's been a variety of presentations. Some have been more research-based, and some have been very deep and very emotional too. So Ronnie and I are grateful to be here with you today as we present on risk reduction in remote care, innovations, and ethics. And as we get started, I want to just share with you the objectives for the talk today. More than anything, as we go throughout this talk, you are going to see that we are really just scratching the surface today with this topic as well. And we really just hope that what we share with you today will help all of us to start a dialogue where all of us can come together collaboratively to share and to discuss difficult decisions to facilitate treatment for those diagnosed with eating disorders. So first and foremost, we want to identify the unique risks and ethical considerations associated with delivering eating disorder treatment. We want to also discuss and evaluate innovative tools and care coordination models that enhance our client safety and support stabilization in remote treatment environments. We want to analyze a case example for you at the very end of our talk today to integrate clinical excellence with ethical responsibility in remote treatment practice. And lastly, we want to integrate ethical frameworks into decision-making processes to promote client well-being and professional accountability in remote settings. And now I am going to turn it over to my colleague, Dr. Ronnie Lee.
Thank you so much, Alicia. I'll second that. I'm super excited to be here. And here on the last day, I just want to give a little bit of love, and maybe we can show some love down in the chat to all of the team members behind the scenes and forward facing to make the summit possible. So many amazing talks, lots of just a wealth of information across the board. But it isn't possible, obviously, without you all attending, without the presenters agreeing to attend, then all of the work behind the scenes to make this what it has grown into over the past few years. So thank you so much. Yeah, I'm excited about today's talk. I just want to clarify a few things. So this is one of these talks that, and I'm sure this happens quite often, that we really could go many, many hours on this topic, and actually probably be best practice to follow up with this talk and do kind of a more like structured, spearheaded approach. But Alicia and I are really just scratching the surface on this topic, understanding the idea of risk reduction, what that means in the remote setting, and how we can utilize this framework to better client outcomes, which is hopefully what we are all here for, right? Is the treatment and betterment of prognosis and outcomes of our population. So when I think about risk reduction, I in my mind, kind of identified two words: prevention and mitigation. Um, One of the things that I want to highlight is that with being a clinician, or really anybody who's working with patients or in healthcare, there is a piece of it that is reactionary, right? So something happens, whether it's in session or whether, you could be in a nutrition session, or you could be with the nursing or in group, and something unexpected happens, right? And that forces us to react on the spot, right? And so we utilize our clinical judgment, clinical acumen, all of these fancy words. And I believe, just in my opinion, to work in healthcare, there has to be some personality trait or characteristic that is we're able to manage this, right? And particular shouts out to anybody who is a care partner or a recovery coach, right? A lot of times we're kind of in these unexpected situations where we have to just act on our feet, or that was unexpected. I didn't think that this brief meeting was going to lead to this, but we have to act, right? And so even though this is true, even though there is this idea of reaction, clinical reaction that takes place, best practice is to avoid that, right? We want to be able to prevent kind of like unknown and unexpected actions occurring, right? So that's why as we're discussing risk reduction, and even as we get into the ethics portion, I want you to continue thinking about the idea of prevention and mitigation. Okay. I also want to just quickly contrast risk reduction with the idea of harm reduction. And if you've been to any variety of conferences and talks over the past few years in the eating disorder landscape, the idea of harm reduction is something that is touched on quite a bit. We are not going to touch on it today. It sounds similar to risk reduction, so I just want to make sure that we are not confusing it. When I think of harm reduction, and this is just my kind of personal idea of it, I think of it as the reduction of symptom suffering, while also maintaining engagement even when high risk persists. But with our risk reduction, again, the ultimate aim and the ultimate goal is to eliminate or minimize risk exposure across the continuum of care. So I take that piece of it, and I also take the piece of each patient that comes to us or comes to anybody. We have to take patient presentation and symptomatology into consideration. And so the idea of minimizing risk and taking each patient for what we see in front of us, to me, that is how we can improve this idea of prognosis through those two lenses. Another piece that I want to touch on is as we're working through kind of what risk reduction looks like, what you'll hear a lot is things like safety and things like protocol. And that's true, right? The focus is on systemic safety and protocolization of many aspects of remote care. But it doesn't solely have to be remote care. This occurs in hospital settings, brick and mortar settings, and in general healthcare environments, right? The more protocols, the more things that are known to the clinical team, the less we are reactionary. Okay. Um, I'm not going to touch on ethics too much because we have probably one of the best individuals to do that later on in this talk. But what I will say is that ethically, this idea of risk reduction is grounded in the principle of non-maleficence, excuse me. And another way to think of that is just do no harm, right? So if we're keeping that into consideration as we work through these slides, I think it should paint a clearer picture. Okay. Um, why remote care? That's obviously a rhetorical question because I myself have done talks on why remote care is comparable, and even in some aspects has better prognosis than brick and mortar, depending on certain variables. So the question really isn't why remote care. We know that it's useful. We know it's helpful. We know that it's a viable option in general. We also know that it works to offer access to underserved communities and creates flexibility in scheduling, work-life balance, school, family. All of these ideas are some of the driving factors behind why remote care has been so attractive over the past few years, and particularly since 2019. But with that being said, there's some trade-offs, right? So as we venture into the world of remote care and our technology improves, and there's more understanding of why this is a viable option, who it's a viable option for, and all of the talks that praise remote care, which I am 100% in congruence with that. It is important to understand that with increased accessibility comes new forms of vulnerability, right? And that comes in many different ways. So some of the areas that we'll look at specifically, things like technology, right? So although technology has just feels like rapidly increased over the past, I don't know, like 10 years. I feel like every few months there's some amazing technological advancement, whether it's AI or whether it's other aspects of technology, chips getting smaller, Bluetooth transmission becoming faster. Um, it doesn't mean that there is no possibility for error with technology. Okay. Operationally, there are a lot of, when I think of this word operational, I think it's something that we are all doing throughout our work day. But it's just something that things that we are not naming, right? So the operational kind of like behind the scenes um, factors that go into being able to offer remote care um, is also a vulnerability. And lastly, the clinical aspects. So when I say clinical, I'm combining in the medical piece of things, psychiatric piece of things, and the safety kind of concerns that can come with not having an individual in person, right? So again, it's our ethical responsibility and clinical responsibility to anticipate and mitigate those vulnerabilities before harm occurs. And I'm going to keep harping on this point of bringing it back to one of the first things that I said, is that even though clinical acumen and clinical response is relevant and is needed in all aspects of healthcare, the more we can reduce that, the better things are. And I don't want to confuse that statement with saying that we should all be robots, right? We should look at each case on a case-by-case basis and kind of understand the inner workings of this particular patient, right? But if there's this underlying framework of understanding and responsibility, as we are also taking that into consideration, I think, again, that's where safety and in general, following the ethical nature of risk reduction becomes apparent. Okay. The other thing that I'll say about this is a lot of times remote care is compared and contrasted with other forms of care, specifically brick and mortar. But I want to emphasize the idea that it really isn't a substitute, right? But it's more so it increases or emphasizes the system of safeguards that need to be in place for remote care to work, right? And so considering the contextual realities, psychological, medical realities of what it means to provide remote care, is important to spell out each of these disciplines, so they all kind of work in this systemic kind of functioning way. And that's something that I'll touch on later, is that this should be kind of this ever, like, even though there should be a level of understanding of what's going on protocol wise, it should be this fluid approach to care in general. All right. Risk landscape. So I'm going to speak a bit on the medical piece on this slide, and one of the slides I have coming up. I want to make it very clear that we have probably some people in the audience, and definitely some of my colleagues who can speak to this medical piece far greater than I can. But it is important to briefly touch on. The other thing that I'll say, and I meant to mention this earlier, is that I'm speaking more from a general sense, right? So in any remote care setting that is treating eating disorders, this is where I'm speaking from, not specifically any particular place of work. Okay. So the risk landscape falls in three main categories, and honestly, we could dissect these even further, but for me, these make sense for this type of talk. The first category is medical risks. And I'll ask you, if you are active in the chat, if you're able to type in the chat, feel free to do so. I'll pose a few questions for you. I popped a few things on these slides, things like electrolyte imbalances, hypertension, bradycardia, but I'm wondering if anyone who is kind of understanding of medical risks that can occur with eating disorders, if you don't mind just popping in any symptoms, signs, diagnoses that also could pose a risk from the medical perspective. So I'll throw another one out there, something like POTS, right? Something else that should be taken into consideration. I saw refeeding pop up.
Refeeding. Mm-hmm.
Yeah, lovely. And so there's many, many, many that I could include on here. I just didn't. The same thing with psychiatric risks, right? So things like suicidality, self-harm, and any comorbid diagnoses or disorders. It doesn't go to say that having a specific comorbid diagnoses automatically propels you into a risk category. That's not what I'm saying at all, but it is something to keep in mind. So mood disorders, or something like bipolar 1 or bipolar 2, where mania episodes could be or are present, things like that. Uh, Things like PTSD, acute stress disorder, really a lot of our kind of like main psychiatric disorders that we see with eating disorders could possibly add to the risk landscape. So being understanding when a patient comes in with that presentation. And then lastly, operationally, as I mentioned earlier, it's all of the things that we're already doing, but just may not be talking about as much, right? So things like confidentiality breaches, right? That occurs obviously in brick and mortar, but there's an added layer to it, obviously in the remote care world. Jurisdictional limits, so things like licenses. And for me, I would also kind of like highlight this. So yes, I am licensed in the states mentioned, but I'm also a PsyPact so, psychologist as well. So like with many therapists, right, we have to be able to balance where we can see a patient, where we cannot see a patient, If we're not licensed in that state, what does that look like? If we have somebody traveling, so a lot of things that possibly the brick and mortar landscape are not hitting on. And then response gaps. So this is also, I would say, not necessarily unique to the remote landscape, but is something that we want to keep an eye on. This happens in brick and mortar as well. Doesn't even have to be eating disorder care, but just in general. I know that there are a few psychiatric providers that will, depending on patient presentation, will say, if there's a no-show and there's no communication, we will then enact this specific safety plan, or we will then call this emergency contact, and so on and so forth. So those are then magnified, in my mind at least, a little bit more in the remote care world, just because we are quite physically distant, right? So each of these requires its own protocol layer. As you can imagine, it's not anything. Yeah, I'm not trying to recreate the wheel here, right? But each should have its own protocol created by either individuals already in that space or taking from research and papers that are already out there, as we'll talk about with like thresholds and things like that.
There we go.
Thank you. All right, so as I mentioned, I'll talk very briefly about just from the medical piece of things, right? So we always want to consider medical safety, especially when we are working with patients who could have possible comorbidities that we were talking about earlier, and that was listed in the chat as well. So one of the first things is define thresholds, right? That's going to be slightly different for each patient presentation. So we'll practice some dialectics here, that we can have these thresholds and we can have kind of these cutoffs that either have been applied throughout the medical field in general, which there are a few studies and a few papers that give recommendation for specific thresholds as it relates to blood pressure, heart rate, things of this nature. And so yes, we can utilize those thresholds and also consider each patient symptom profile, as I mentioned, but thresholds are needed, right? So, if the medical provider is not available at that moment, but we see a specific reading coming through, or we see an impacted lab or something like that, right? There should be this kind of automatic course of action that is triggered to then alert, to then therefore come to a decision, right? Require verified at-home vitals and secure submissions. This kind of goes back to the technology piece a little bit as well, with the medical flair of it. So obviously we need to have verifiable at-home vitals across the board. Any remote care facility would need that and need it to be secure, right? One of the ways that we can ensure secure submission is by allowing third parties to access and be able to double and triple check, right, that these vitals are accurate, right, and that we are having this pretty fast and secure relay system going on behind the scenes. Again, I do want to also highlight the fact that it's not necessarily just remote care. I recently went to what's the facility? I think it's called One Medical. It's a little bit newer. It's like through I think Amazon. So I tried it out. Super high tech, or at least to me, it was very high tech. Virtually everything that I would have seen kind of like an automatic number presented. So things like my blood pressure, O2 sat, weight, things like that were all Bluetooth enabling, I'm assuming Bluetooth synced and transmitted, right? So the idea that secure submissions only refer to the remote care landscape is not true, right? The field in general is moving toward this kind of like a more fluid approach to utilizing technology in a lot of different ways, right? So, of course, though, it's up to the facility to make sure that things are secure and that things are working correctly. One of the other things that we can do to help verify vitals, right, is utilizing this hybrid approach that we'll talk about in a little bit, specifically just asking clients to go in person, right? Kind of mixing that in as much as we can. And there's this model of like a ratio of what a hybrid care model can look like, and why it could be helpful. So utilizing that kind of ratio created by the team and making that a part of care can help with verifiable vitals and making sure that we know exactly what's going on with our clients. Uh, Regular labs for refeeding and other comorbid conditions, or just lab work in general, right? We understand how important it is to be able to understand what's going on physiologically with our patients and have those readings available to be able to guide treatment as well. So obviously it'll be up to the medical provider in terms of how often these labs are needed, and which labs are needed, right? But the idea of having regular labs is something that is across the board accepted in the medical community working within this population. And as I mentioned earlier, whenever possible, obtain supervised weights or clinic verified weights, right? So it is good practice, I think, in general for as many weights as possible to be supervised, eyes on. Not that we don't trust our patients. Of course, we trust our patients, but it is our way to ensure that in this remote landscape, we are trying to reduce the amount of variability that could occur across the board, right? So again, mixing in clinic verified weights, making sure that the provider on the other end of things is understanding of what we're doing and why we are doing it. I recently had a patient who had to go for in-person weights, and I'm sure that what I'm about to say next isn't new to many providers in this space, but sent them in for weights. They saw their weight. They were given a piece of paper, saw their weight. They're allowed to be weighed with their shoes on and kind of items in their hand, right? Just things that if that communication piece is there and kind of the conversation between clinic and care team of what we're doing and why we're doing it becomes more and more apparent. And onto suicidality and risk protocols. So again, this is going to be kind of facility dependent. Yes, there are like overarching protocols for or just top-down kind of protocols for what should be included in safety assessments, what should occur prior to an individual admitting to us or admitting to any facility to reduce suicidality and reduce any risk in this area, right? So it can never be zero risk, right? There's always some risk when we are working in this landscape. And a lot of the work will come, and again, across all facilities will come prior to admission, right? So that's where the majority of this information is so important to obtain, is understanding, okay, as this person is coming into our care, this is their risk assessment. This is where we think they can fall. This is where we think they can flourish in the remote care or not, right? Depending on risk level. So important when they're in care, right? So to always identify exact location and local emergency contact information. This goes without saying, but the remote facility, there's a lot of it could be a challenge to like accurately locate. So that's where having a um, good relationship with that patient, with that client, and making it clear as to why we need to know exact location and have local emergencies written down if that location changes. These things may seem redundant or may seem unnecessary, but again, in the case of an emergency, in the case of something going awry, it is important to have that plan ready to go. as I referenced early on, we want to make sure that we're avoiding situations where we're reacting just on the spot. Although many people can do that and do it well, the idea is to try our best to mitigate the human error that can occur across the board for anybody. We want to be able to identify and use structured safety plans and utilize handoffs. So when an individual is coming in, one of the first things that should be done is kind of this risk assessment and safety plan creation, right? And that data, that information should be given as a warm handoff to the clinical team, specifically to um, individuals like nursing, psychiatry, therapy, right? All of the kind of hands-on with safety to make sure that these checks are or that everybody is in congruence with level of safety, and that everybody's understanding of the safety plan and what this means. And lastly, documentation and communication. Um, for as much as I talk about and others talk about the um, viability of remote care, right, and it being this growing, kind of bustling field, um, research looks great in terms of outcomes. One thing that isn't easy to replicate is if you've been in brick and mortar before, and again, I'll utilize myself for an example. Um, our office, so to speak, was in the middle of this house, right? Residential facility, and in that room, there was, therapy, there was nursing, psychiatry, office was in there, recovery coaches were in there, and so on and so forth, right? So one of the things that happened is that we didn't necessarily have rounds or staff meetings every single day, right? But there was this constant communication, right? With, okay, you saw this person coming back, how are they doing in that moment? And we're just almost always updating our idea of how this patient is working through the program, through said program, what is going on and why it is going on, right? So in most cases, there doesn't need to be these like long drawn out updates, right? Because you're kind of in that environment and you're doing it regularly. So one of the things that sometimes does not happen in the remote setting are those kind of like small talk communications that go a long way. So obviously there's a lot of ways to work around this. Things like scheduling coffee time, things like scheduling it's also kind of known as like tea time, where you get together with the team outside of the staff meeting, 5 to 10 minutes. Like, hey, these are kind of the updates. This is what I'm thinking. This is what's being changed, and so on and so forth. And one of the things that this also does is it helps alleviate this idea of like having to read everything in the remote care setting, right? So in remote care, we're doing a ton of reading. We're reading updates, we're reading notes, we're reading X, Y, and Z. So having areas and specified times where you are just with the team chatting, not in the structure of a staff meeting. I know that is difficult to do because of time and trying to be amenable to everybody's time and everybody's schedule. But if possible, I do think that this is best practice within a clinical care team to be able to communicate on a high level. So I know I briefly went over a lot of things that I'm sure that you all already know, right? This should be common knowledge, the medical risks and what needs to happen in that realm, the psychiatric risks and what needs to happen in that realm. But I want to reinforce and highlight that these are not just checklists, right? So it obviously seems like checklists, like, okay, client location, check. Do we need to update emergency contacts? Nope, check. Did the patient weigh in on camera? Yes, okay, check. So it can feel like there's a lot of checklists that have to be done to move on to the next step. And while part of that is true, there is some checking that has to occur. The greater idea or the greater theme that I'm trying to push is that this sh th this should all be occurring within a living, breathing system of accountability, right? And so the more that that's kind of the way that we're thinking about it, is that each person is doing their job and working through their area of expertise, and they're also relying on the person next to them in another discipline or within the same discipline to be doing the exact same thing. There is this kind of shared accountability um, throughout said facility, right? And so if that is hit, if that is matched, then um, we would assume that outcomes are better. Things like prognosis is better. Things like lack of reactionary situations are reduced, right? And there's kind of like an identifiable step of um, what to do next, right? Which can ease worry, ease clinical anxiety, and even ease maybe like patient unknown as well. All right, so for me, and hopefully the majority of our talks, research always guides the way. There's just a few models that I want to chat about. I'm not going to go too in depth again because of the time. We just don't have the time to go fully into these models, but I encourage you that if they do sound familiar, you'd like to take a look specifically, to please do. So one thing that I will start with before we go to the next slide, family integrated care. I'm not going to highlight any specific model, but what I will highlight is just the idea of this being quite important, okay? Uh, I believe Ali gave a talk yesterday, and Ali, if you're in the audience, that was an amazing talk. But a lot of what was touched on, right, is that family integration increases or increases positive prognosis and outcomes, right? And so we know that this is true. It's research backed. We kind of take this as a fact. And the other piece of it is it also works in the clinical favor, right? Because if as we're doing family therapy and as we're doing this kind of like these psycho ed sessions, we're also integrating this idea of patient trust and ultimately safety, right? We're reducing risk. The more individuals that we have around our client that are involved in treatment, that the client trusts to be involved in treatment, and that there is this kind of like working family integrated trust going on, the more that we can reduce risk, right? Because there are these kind of natural like safety pitfalls that we can enact if needed with a family member. Doesn't mean that it doesn't happen if a client is not able to integrate their family or is unwilling, right? It's just one of these situations where family integration can increase the likelihood of understanding how to reduce that risk. All right. So on the screen, I apologize. I see it now. It doesn't look like the prettiest table, but this model is from the NEDC, and I just want to take a moment to walk through it. I'll just spend a few minutes on it because I think a lot of this is known knowledge, but maybe just hasn't been spelled out in this way. So this describes an integrated system, as you can see here: prevention, identification, response, treatment, and recovery. And really what it aims to do simply is that we really just want to make sure that each patient is getting treated at the appropriate level of care. Now, does that always happen? No. Why does that happen? For a variety of reasons across the board. Taking eating disorders outside of it, it happens all over, right? Whether it's medical care, mental health, or other areas of functioning. In a perfect utopian world, each patient will be met with the care that they need at that level of care and at that time. We just try our best to follow this model. Prevention, it involves like actions, programs, policies to reduce overall risk, and kind of challenge some of these like culturally persuasive like ideas of what an eating disorder is. I'll put it like that. We try to strengthen protective factors like body acceptance, resilience, things of this nature. We recently just had Weight Stigma Awareness Week, which fits perfectly into this idea of strengthening protective factors. Um, it's important to keep in mind that this is a shared responsibility, right? So you may be thinking to yourself like, well, we're talking about like actual treatment of the eating disorder, not prevention in this talk. And while that's true, um, the collective goal, I would think, of our patient population and in general treating community is to reduce the rates of eating disorder, right? So it starts at at the ground level. It starts with outreach and things of this nature from all facilities. Want to be able to identify, right? So that means identification at a medical office, identification at school, identification at different clubs or sporting events, which is a really big one. Michelle and Kat gave a talk yesterday about athletes and eating disorders. And so it can present in different ways, right? So as we're doing more outreach, the idea is that our identification can get better to be able to know who to bring to that initial response stage, to have the preliminary assessment, provide psychoeducation, and provide referrals based on psychological functioning, physical functioning, and general nutrition and dietary needs. In the treatment realm, I'm not going to spend too much time, but the kind of general, kind of accepted model, right, is inpatient, residential, PHP, IOP, then to community outpatient. That obviously is not the step-down process for the majority of patients, uh, but it is best practice to try to align that specific patient with their level of care put about by guidelines. And lastly, I'll just add in the psychosocial and recovery support, which is such a, I think sometimes an overlooked piece of things, but very important on my end. And I assume that many in the audience, right, is that this piece can really make or break it. I'm big with analogies, and the analogy that I always think about is if someone is leaving our care or any remote facility care with as or on a sailboat, right? And you have one individual who has like, well, now that I think about it, I should probably pick an analogy that I know more about. I don't know anything about sailboats, but if somebody has like a backup sail or maybe some like rubber bumpers on the side, if you encounter rocks or something, extra food and water, no pun intended, and yeah, a lot of kind of like safeguards, right? Versus somebody maybe across the harbor also leaving, and they're just like, well, I have my boat and everything seems to be working okay right now, and I hope that it works out well. We want to be able to make sure that everybody it feels like they are the former sailboat, right? That they have helplines and resources to reinforce that long-term recovery and quality of life. All right, and I'm going to speed up here just a little bit. So I'm not going to talk too much about the hybrid model, mainly because I talked about it a little bit earlier. But the idea behind this hybrid model is that there are 6 key elements: sociodemographic factors that contribute to treatment context that then kind of like guides this ratio of in-person to virtual. It's really interesting. I encourage you to take a look at it from Novak and Chadi 2025. But the idea is that uh, taking each person on a case-by-case basis and identifying how much in-person activation is needed. And so the model that they put forth, it truly is this like hybrid remote and in-person model. But I would argue that even in if you're working in a fully remote facility, that there is a portion of hybrid uh, uh, modeling going on, right? So if somebody is going in to see their specialist, if somebody is going in to see their PCP routinely, blood work, routine weigh-ins in person, that's a form of kind of enacting this hybrid model, right? And the ratio, again, is determined by patient severity and kind of what we are considering with each specific client. So the idea behind this model, briefly, in sum, it's to help clinicians and care team members calibrate care intensity when needed. All right. Things that are, I would assume, kind of already understood, but just to quickly go over and highlight. And this is across all disciplines, right? So before each appointment slash session, right, things like confirming client location goes a long way, understanding emergency contact situation, device readiness, kind of understanding that things are working appropriately and properly so that we are able to read trends in real time. During, we always want to verify privacy, and not only obviously for the company, but for the patient as well. Review vitals, slash outcome measures with that individual, and then do our own due diligence and screen for any new risk that has emerged. And obviously afterwards, document and communicate updates. I passionately said how important it was to be able to communicate with your care team member if there's any subtle or significant changes occurring within this client presentation. Um, yeah, thank you, Alicia. I was trying to think if there was anything else. And then triaging, a word that I'm sure we are all familiar with and has been around for decades, probably centuries actually, is that if vitals are safe, if the presentation and the symptomatology is considered safe by the care team and by the protocols, then we want to continue remote care. Obviously, if borderline or yellow comes about, we want to be able to increase monitoring and revise the safety plan. And then lastly, if we consider that there is a threshold breach, we want to escalate to in-person evaluation or include other medical professionals if needed. Okay. The idea is that decision-making should align with clear company-wide protocols, right? And that's something that I will end with, is that although it may sound very robotic and that we're taking the client perspective out of it, it's actually the opposite, right? If there is a company-wide protocol that allows for this strong base framework so that if a client comes that there needs to be some shifting or some flexing, we still have a strong framework underneath it, and then it is up to the care team and medical professionals to flex as needed.
Thank you so much, Ronnie, for awesome content. And we are now going to get into some of the ethical principles. And as you've already heard a couple times, how we are just scratching the surface here. So, in consideration of time, I am going to talk about some of the ethical principles as it relates to eating disorder treatment, remote care, and I want us all to be mindful that this is typically a 3-hour presentation that I do. So I am going to go through many of the concepts in a 30-minute period. So again, when you think of scratching the surface, we are definitely scratching the surface here. And if, I'm going to say if we have time to get to the case study at the end, you will see how some of the principles that we are going to go through now will drill down into that case study. So in order to set the table for this next section, I just quickly want to give a definition of ethics, and I hope you all don't mind. I have to look at this other screen over here. We were talking about screens earlier and how some of us are at that phase where we just need a larger screen. So when we think of ethics, ethics are a moral code that really provide guidelines to shape behavior and inform clinical decision making. They often describe for us the difference between good and bad, right and wrong, and they are often based on values. And there are no hard and fast rules when it comes to resolving ethical dilemmas. So, um, I'm not going to use Ronnie's sailboat metaphor, but I also like to use metaphors. And when I think of ethics, I don't know if we have any tennis players or pickleball players out there, but when I think of ethics, I like to think of being out on the tennis court. When you're playing tennis or when you're playing pickleball, there are so many different things, so many different techniques, strategies that we have to balance. We have to think about ball placement. We have to think about foot placement. We have to think about racket placement, all strategy, where we're going to hit the ball, all these different things. And when it comes to ethics for me, that is what I think about too, is we've got, if you will, all these balls in the air, all these different things that we are trying to keep in our heads at one time so that we can really make the best and the most informed decisions for our client, especially when it comes to this idea that we are focused on in this presentation of reducing risk for our clients. So I want to first cover some ethical principles. The ones that you see in italics on this slide and the next slide are the ones that Ronnie touched on as he was talking about some of the risk reduction models. So at the core of ethical decision making, are these various principles. So we all, as Ronnie already spoke about, have governing bodies for medical and mental health care disciplines. We all have various ethical codes that we have to follow, and that provides a core set of principles, a framework for us to shape our clinical practice and to inform our clinical decision making. In addition to ethics, we also have to take into account rules, any regulatory bodies, any accreditation agencies, and laws to ensure that we are upholding the highest standard of clinical conduct and excellence. So, first and foremost, ethical decisions are going to involve clinical judgment, best practice guidelines, and consultation among team members. So that collaborative nature of the work that we do that Ronnie also touched on as well. So for autonomy, we want to respect our clients' rights to independence, freedom of choice. We want to respect their right and dignity. And autonomy is a fundamental right of patients to make their own decisions regarding healthcare. We also want to take into account beneficence, and this is doing good for others. This requires a professional to work within the scope of their practice, of their discipline, of their work. And it's an ethical duty of healthcare providers to also act in the patient's best interest. Non-maleficence, that is not inflicting harm or actions to inflict harm on our clients, on our patients. So where benefit and harm exist, that is a both and. We want to take into careful consideration, is the benefit going to outweigh the harm? So for example, it might be a medication. If a medication has proven not to be effective for a client, is that medication then going to be withdrawn for this particular client? And then lastly, fidelity. We're going to touch on this a little bit too. This is honoring the therapeutic relationship, honoring the commitments that we have also made to our clients. So research also shows that the therapeutic relationship, that collaborative partnership between the patient and the provider is often the key in terms of getting clients to agree to treatment goals. And often, if there is a recommendation for a higher level of care, getting the client to realize that perhaps that is in their best interest. And we also have integrity and veracity. We want to ensure that we are presenting facts very carefully, very clearly. When we have that collaborative partnership with our patients, it's easier for them to understand, to hear, to listen to the explanation for why we are perhaps recommending a particular evidence-based type of treatment, why we may be recommending a particular level of care. And we also want to take into account, are there some areas possibly where we can flex, some areas that we may be able to negotiate? When it comes to justice, some disciplines believe that justice means equal treatment for all, and some believe that justice means that everyone doesn't receive the same treatment, but they receive the treatment that is individualized, that is best suited to their needs. Paternalism is a concept that you are going to see that in medical and mental health, we're seeing a shift away from. We are seeing a shift towards a more patient-centered approach. So paternalism is described as power over the patient. And again, it comes down to really looking at the benefits versus the risks. Are there medical safety issues at play here? And again, we want to balance that also with a patient's autonomy. And then lastly, the duty to protect. First and foremost, protecting our patients and others from any foreseeable harm. So ethical considerations when it comes to eating disorder treatment. Again, we do not have any hard and fast rules for managing ethical dilemmas. There is nothing that says this is the right way, this is the wrong way. Oftentimes, things are not clear. And so we find ourselves as providers weighing the pros and cons, trying to make a decision that is going to benefit the patient and their family while also limiting potential negative consequences. So we want to understand the patient's, and I like to say, quote unquote, resistance, because we also want to take into account, what is the function of the eating disorder? What might be driving the patient to want to maybe go in this direction when maybe we're saying, we need to veer a little bit to this direction. As Ronnie touched on before, we also want to take into account some of the co-occurring diagnoses. Those really may give insight to the impact of the severity of the eating disorder. And this also helps to assist with treatment planning and also for us to assess motivation for treatment and also for recovery. We really want to work on harnessing the power of the therapeutic relationship. Often that is the key to treatment planning, getting our clients to agree on particular goals for treatment, and also when it comes to recommendations around certain levels of care. I know you all out there do a really great job in developing strong and authentic relationships with your client. And I also want you all to keep in mind that that really has the power to motivate a patient to change. There was also one study by Norman Faust, and he, if I remember correctly, was out of the University of Wisconsin. And he did a study on 4 different things that led to patients agreeing to treatment recommendations. And he also harnessed the therapeutic relationship. And one of the things that he said is the patient likely to be angry with you following your recommendations? So keep in mind that if you have a positive working and collaborative relationship with your patient, they are likely to hear what it is that you are saying to them in terms of treatment and recommendations. We all want to hold that empathy, that validation for our clients. And I also like to harness what we call the 4 C's when it comes to meal support in terms of strategies to build a therapeutic relationship. And that is being calm, being confident, being consistent, and being compassionate. Other things that we also want to take into consideration are denial of the illness. So remember, sometimes eating disorders can be deceptive. Some patients want to deny the severity of their illness. They want to resist treatment. So in some instances, it may be medically, legally, and ethically necessary for us to make certain recommendations that's some of a little bit what we're going to see in the case study, again, if we have time to get there as well. So we want to be very careful when we're making recommendations to consider, is this violating a patient's autonomy? And also want to look at, is this imperative for the patient's survival and recovery from the illness? So again, we find ourselves in this ethical dilemma of autonomy versus duty to protect. For our adolescents, especially when it comes to developmental needs, we know that our adolescent patients are in this critical phase, not only of brain and bone development, but they're also forming their identity. And so a stable sense of identity has not yet been formed at this point. So, something also that we want to take into consideration when it comes to their treatment needs. We also want to look at the eating disorder. Severity is one's physical health being impacted. We also want to look at evidence for effective treatments. So, we especially need more studies in this area, especially when it comes to this idea of risk reduction, or as Ronnie started to kind of move towards a little bit, harm reduction, which is something that we are starting to hear a whole lot more about in our industry as well. We also want to look at treatment approaches and treatment at lower levels of care, given that eating disorders already are so complex. We want to utilize that multidisciplinary team approach. And again, we also want to look at risk versus benefit with particular decisions. Also, for us as providers, when we think of misunderstanding and stigma, I like to kind of relate this back to the provider as well, especially when you are working with a multidisciplinary team. It's really important for all of us as providers to know if we have any blind spots, or is there something that may impact some of our decision making too? Is that going to impact the entire team? Is that going to impact our patients? And again, in the 3-hour talk, I delve a whole lot more into that as well. In some areas, we also want to look at one's decision making capacity. So, in ethical considerations for eating disorder treatment, there are some studies that begin to look at capacity and competence. We are certainly not going to get into that today. And restrictive treatment when a client is in a life threatening situation. So again, I wanted to pull out a few of these concepts and delve into them just a little bit. So when we think of improving resistance, promoting recovery, a lot of the research shows that motivational interviewing in combination with various concepts and modalities from psychotherapy are best going to meet our needs, are best going to move our patients into that direction. We also want to prioritize our treatment targets. So, is weight restoration our primary target here? What else are we looking at as well? And again, I think a lot of this too really ties into what we talked about, really using that therapeutic relationship to delve into conversations with your patients about the illness, about the function of the behavior, and really balancing that acceptance and change, validating acceptance and validation with firm empathy or change. And, as we all know, that's really one of the hallmarks of dialectical behavior therapy. And where we can, we want to lean into our patients' autonomy. We want to be able to work collaboratively with our patients to affect change. That is where we are going to see most of the success with our patients when it comes to treatment. So staying at lower levels of care. I know that this is I've been in this industry for a few decades now, and this has always been a conversation, that is very necessary as well. So when a patient insists on staying at a lower level of care, I know that all of us have been impacted by that at some point in our careers than clinically indicated, then we are faced with an ethical dilemma as well. And Ronnie touched on that a bit too, in terms of bringing the team together. So when we know a patient cannot be maintained at a lower level of care, what is it that we as providers do? Um, so, of course, I want to bring in some of our ethical guidelines here as well, particularly autonomy, fidelity, duty to protect, beneficence, and non maleficence. Um, but remember, our patients have a right to have a say in the level of care in which they receive treatment. That is what we are seeing our industry move towards. That's the patient centered care, much more so than when I first started out in this field. The ethical conflict occurs when the patient fails to make progress at the decided level of care, or if the patient begins to decompensate to the extent that their medical safety is jeopardized. So, recommendations are for the provider to outline the benefits and the risks of staying at a certain level of care. And again, this goes back to that idea of what we talked about before as well. Patients are more likely to agree and listen to the recommendation when they too are involved in the process, or for an adolescent, when the family is involved in the process as well. And continuing with this idea of staying at a lower level of care, we also want to take into consideration the duty to protect, non-maleficence. Those principles designate that the provider must do what they can to ensure that the patient's health, first and foremost, is the primary concern. So, continued treatment at a lower level of care than is clinically indicated, we want to look at, does this pose a significant risk for the health of the patient? Is keeping the client or the patient at a lower level of care contributing to prolonged illness, chronicity, and lifelong lasting medical complications? So, clinicians can intervene to protect the relationship when the behaviors can not be managed. And again, we want to pull in our multidisciplinary team. That is critical, that is essential, because everybody, remember, does something different on the team. I like to say that eating disorders being such a complex illness, we've got the nutritional, we've got the medical, we've got the therapeutic, we've got the psychiatric, and each discipline is pulling out their piece. But again, we're kind of doing that dance and we're coming back together as a team to really highlight the benefits and the risks. Everybody on the team has input as well, but we also want to keep in mind too that our patients are a member of the team as well. We want to outline for our clients what the deal breakers are of staying at a particular level of care as well. We want to say, here is what we need to see as well. And going to try to get us to the case study so we can talk a little bit about that too. So, ethical considerations when it comes to remote care, I really drilled this down for all of you. I've normally got about 30 pros and 20 cons, but I'm going to highlight some things here. I know Ronnie already touched on a few. Obviously, access to care. COVID-19 really led us into this realm of remote treatment. There are very strong outcomes out there for virtual programs. I really just want to highlight that. One of the things we've seen in the field is that there is an assumption that brick and mortar programs are superior, and the research absolutely highlights that there are very strong outcomes for virtual programs as well. But these are some of the ethical things to take into consideration. If you work remotely as well, regardless of the level of care, we know it does increase access. It is beneficial for many of our patients. Many of our patients may not have sought out treatment, or perhaps they did not have a treatment program catering to eating disorders in their area. Um, Patient privacy in some instances actually is enhanced, especially in our smaller communities where a client is perhaps likely to see somebody they are close to in their community in a provider's waiting room. They now have more enhanced privacy. Patients feel more empowered, they feel more in charge of their treatment. And this might be a way for a provider to connect, as I said before, with a patient who may have not been likely to have sought out treatment. So for some, this might be a stepping stone into getting the care that perhaps they have needed. It may be a way for some to increase their attendance if they have a difficult time getting out of the home. Ronnie talked a little bit about considerations when it comes to handling emergencies. We also want to ensure when it comes to informed consent and taking into account ethical considerations as well, that we are outlining for our patients the benefits versus the risks of telehealth treatment. And as I said, we have very favorable outcomes. And then we also want to be very clear when it comes to informed consent about the steps that we would want to take when it comes into the event of an emergency. We certainly want to identify, we want to have ways to identify that the person on the screen is actually the person that is outlined or signing off on the informed consent. And I know Ronnie briefly touched as well on technical issues and some of the boundary issues that we can encounter as well. So I will not delve into those. And then when it comes to ethical decision making as well, we want to really collect as much information as we can. Remember, we can never know everything, but we want to collect all relevant information needed to make an informed decision. And again, we want to come to the table already knowing what are our blind spots? Are there any biases that might impact our decision? We may want to consider our code of ethics for our particular discipline as well, any legal requirements. Ronnie also touched on state licensing requirements. We also want to look at regulatory requirements and requirements from accreditation agencies. Seek consultation where needed. I always like to say there is no shame in supervision or consultation, no matter how long you have been doing this. I know for me, sometimes talking out loud about something helps me really to, come up with ideas that maybe I would not have thought of if I were just sitting by myself, typing up something or writing it down on paper. So there is nothing wrong with really following a structured model as well. When we need to come up with alternate solutions, we need to look at the pros and cons. One of the helpful strategies is even using something like the pros and cons strategy from dialectical behavior therapy. On one of the next slides, we're also going to cover an ethical decision-making model. So there are various ethical decision-making models out there. One that I still like to use is one from the early 90s. I know that sounds really outdated, but they are all still relevant, in this day and age as well. And again, I just want you all to keep in mind that there is no right or wrong answer, that different people are going to respond in different ways. So that is why it's critical to bring together your multidisciplinary team. You want to implement what it is that you as a team all decided on. And then after the fact, come back, almost like a root cause analysis. You want to come back, you want to evaluate the process that you went through, your decision, and what is the outcome of that decision. Oops. There we go. Okay, so ethical decision-making models, these are helpful for, less seasoned clinicians, or again, when it comes to clinicians needing to carefully, logically, and thoughtfully think through an ethical dilemma. These models can certainly be useful too when, if you think back to several slides when we were looking at all those different ethical concepts, it can also help us take and break down all those different ethical concepts and how do we apply these different ethical principles to the situation. A model can also remove some of that bias, some of that subjectivity, and perhaps any individual judgments that might cloud either you as an individual or cloud some of your team members from making a sound decision. And as I mentioned before, it was the American Counseling Association had a model that they put out in 1996. again, it's just a model. It's not necessarily walking you through any particular ethical principles, but it did take into account some of the various stewards of counseling ethics as well. And self awareness is also a key to competent decision making. So, therefore, also a key to competent, ethical decision making and problem solving. So, lastly, for consideration, as Ronnie had mentioned, 2019 was really the start of remote care models. And then COVID-19 in 2020 really sparked more discussion around the need to do more research around risk reduction models versus a true abstinence model. And some of the risk reduction research that we did come across was really pulling from substance use as well. So if you do delve into this topic, you will see some of that out there. Risk reduction really aims to look at reducing the medical and psychological impact around eating disorder behaviors. And for some, especially around COVID-19, really looking at what the function of the eating disorder was. For some, it was a way to cope with the uncertainty of the time. So, is there a way, as we're thinking of risk reduction, and as I talk about this, we're not necessarily endorsing any one approach, but is there a way to maintain some behaviors while also increasing the safety of the client, the eating disorder behaviors? This does provide the client, the patient, with some autonomy and self determination. What is normal eating? That's something we want to delve into. What does our client consider normal eating? Um, and again, this really highlights that person centered approach that we are also working to incorporate. Um, we know that our patients are also experts on their own body, on their life, on their health. And a risk reduction model does take into account some of that, really, as do all models. But that was one of the things that was highlighted as well. We also want to look at, can we still reduce the harms of these behaviors if some of the behaviors are still maintained? So, for instance, if we say we're going to, instead of getting to this weight, we're going to get to this weight, what we have to ask ourselves, is harm being reduced enough? So, overall, I'm going to kind of end here, but overall, we want to consider the goals of treatment, possible outcomes. So we want to be able to not only focus on what's happening now, but we want to be able to project, think ahead, what are possible treatment outcomes. We want to take into consideration the function of the eating disorder, family involvement, and any research. One of the questions I know in some of the research that was posed out there is risk reduction a viable option as a way to avoid higher levels of care, if you will. One study did posit that such a model might be appropriate, especially in cases where a client perhaps has not been successful in treatment for a 5 or 6 year period of time. This was one of the models that they were starting to take into consideration for long-standing eating disorders. So while risk reduction may not be a viable option in the short term, we have to also think about, is risk being reduced enough, taking into account, again, all the ethical principles many, many slides ago that we talked about. First and foremost, one of the other things to think about too is, where at all possible, full recovery is possible when treatment commences early on as well. So now with remote treatment and access to care, we are able to get patients into treatment sooner than may have been likely previously. So we want to look at other treatment modalities where there have been multiple failed cycles as well. And again, just as we come to the conclusion of this ethical piece, again, looking at the benefits versus the risks of various treatment modalities. Can there be a both and? So I will end there on the ethics piece, but just things to get your mind thinking thinking about, where you as a provider, what it is it that you are endorsing as a treatment modality and pulling in, not only some of the things that Ronnie talked about on his slides, looking at safety, looking at operations, looking at the medical, looking at the psychiatric, also combining that with some of the ethical principles that we just went through. So, going back to those analogies, it really is a pickleball game and it really is a tennis match. There is a lot to take into consideration. So again, we just wanted to provide some concepts to you all day to just, get us to start thinking together. We're all in this for the same reason. We want our clients to achieve a full recovery, and that may not be what they are ready for. That may not be what their goal is. So, hopefully, as Ronnie mentioned, we can do a part two to this at some point and get a little more granular into some of these concepts. So, it looks like we do have a little bit of time for the case study. So, I am going to turn it back over to Ronnie.
Yeah, thank you so much, Alicia. Just a few points. I think, well, firstly, that's it's a great look into the ethics portion because, as I mentioned in my 40 or so minutes, that was the one thing that I did not touch on. I wanted Alicia to do this kind of a clear outline as to why ethics is so important in all disciplines as we think about risk reduction and what is best for our patient population. I think the other thing that I want to make sure is highlighted here, as I've talked a lot about the protocol piece and how a facility should function and best practices. And Alicia also dove into the idea of ethics, and it's these very kind of like specific parameters. And while there is some flexibility, a lot of times ethics, or they're meant to be quite black and white, right? Um, we know that that's not the real world. So that's something that we're also wanting to put forth, right? Is that when having these difficult conversations, when making maybe some difficult decisions, what we haven't touched on, what is very important here, is that client clinician relationship, right? There has to be a level of trust there. And does that always happen? No. Are there variables that impact level of trust within with the clinical team? For sure, we know that we have many patients who come in with treatment trauma and past experiences, or general just interpersonal trauma that impacts this, among many other things, right? But if we do our best to um, try to create an environment where the patient feels that they are heard, and that there are no surprises, this goes such a long way. And that's something that I always try to reinforce at every level of care, is that there will never be any surprises, right? If we're doing things appropriately and we're sticking to our functions and protocols and using ethics, surprises should be limited, right? And it goes back to the first thing I said about the idea of reaction always being a good thing, right? I wanted to make sure that was highlighted. And now I didn't leave myself enough time for this case, but very quickly, uh, uh, 29-year-old female living in a rural East Coast town. They presented with ANBP and panic disorder. The binge purging was occurring multiple times a day. I don't have on here, but I'll add there were impacted labs, a lot of concern. A variable to this case was that this individual was on a treatment scholarship, and verbalized, that they were having a really rough time, really wanted to make it work, and was kind of reluctant to any other step ups at the time of admission. It was their fourth admission in a row. So to some of the points that Alicia was talking about, taking this into consideration. Presentation was quite complex with everything kind of combined. Although I will say family involvement was at a moderate to high level, which helped quite a bit as we were trying to identify ways to facilitate the transfer to a higher level of care. Eventually, there was a lot of pushback at first because of the multiple admissions. but eventually it was agreed upon that there was a higher level of care. But this is where we started to run into our problems, and this also goes into maybe um, some of the other kind of health equity pieces of the remote care environment and just in general the eating disorder care environment. So there was significant amount of time between admission to said higher level of care facility. So we, as a team, decided that we would hold this client, and that looked like a combined effort from all fronts. So the medical stepped in and identified some very specific threshold. It was communicated to the patient, like, hey, these are the behavioral cutoffs that we worry about. These are the things that if occur will be a sign that we may not be able to hold you for as long as expected. There was an ER visit in there because of impacted labs. But in general, what I will say is that this individual is trusted the process. They routinely showed up to the in-person visit, which we were having, I think, once a week because we were quite concerned with this client. Vitals were happening 3 times a week, and then sometimes kind of sporadically in between, just depending. And just to wrap it up, all of this, there's a lot more that went on behind the scenes, so much more, but clearly there was a great deal of communication going on with family, with outpatient providers, within the clinical team itself, that just harkens back on a lot of what we were talking about with communication going such a long way into making sure that this client in specific was getting the care that they needed, even when they were on the way out to another facility. So again, I wish I had a bit more time to expand on this because I think there's a lot of like working in unison that we can learn from it. But for sake of time, there's our case study.
And we have several pages of references. So if anyone is interested in our references or, wants to follow up with either myself or Ronnie or both of us, there are our email addresses as well.
Thank you so much, Alicia and Dr. Ronnie Lee. If you all just look in the chat, you're getting some love there. Thank you, Elizabeth. Says, thank you, Ronnie and Alicia, for your expertise. Great presentation. And it looks like there were other attendees that were putting things in the chat. Core coring, substance abuse, OCD, EDS, GEI, and diabetes. There was one question that we did receive from Kelly. Kelly says, do you connect with My Clear Step or Weight and Vitals?
I don't believe it is specifically ClearSet, but it is the similar it's similar functionality. So it's a partnership of another company that allows us to do numberless weights and vitals. So very similar to ClearStep.
Yes. I cannot remember the particular brand myself, but very similar. Yes. It is Kenobi.
Ashley has her back.
Kenobi. Thank you, Ashley. Thank you, Carissa.
Thank you. And again, thank you all so much. We are actually at time, so we will have a brief break and then you can hop back on for a conversation that I will be having at 12:45 with a film producer that is telling her shared stories. So please take a moment and then join us, and we'll see you shortly. Thank you so much, everyone.
Everyone, have a wonderful day.
Thank you.
Bye.
Bye.